The following podcast is part of a certified educational activity titled Following the Evidence, LDL-C as a Path to Reducing Cardiovascular Events, How Low Do We Go? Featuring Drs. Mark S. Sabatine and Michelle O'Donoghue from Harvard Medical School, Dr. Robert S. Rosenson from Mount Sinai Medical Center, and Dr. James A. Underberg from NYU Medical School. Access the entire activity and complete the post-test at www.peerview.com/JCD. Downloadable slides and practice aids are also available.
Good morning, everyone. Thank you for joining us for this morning symposium at a busy but chilly AHA. But it's really the perfect time to discuss these issues. A lot has been going on for lipid-lowering therapy. Multiple trials have been presented. Odyssey Outcomes just published in the New England Journal just earlier this week. And then, of course, the new guidelines coming out at the start of AHA. So I'm Mark Sabatine. I'm joined as part of the Boston contingent by Michelle O'Donoghue, also with me at the TIMI study group in Boston. And then we have our New York side of the panel with Robert Rosenson from Sinai and Jamie Underberg from NYU. So really, in my mind, this was based in part on a talk I gave at ESC, where I was asked to talk about the topic when statins don't work. And I kind of changed the premise, and that it's not that statins don't work. It's in fact incredibly rare. Most patients have a very good response. Of course, it depends on the drug and the dose. And there are some individuals who are truly statin intolerant, but that's typically a slim minority, at least in general practice, perhaps different in people who have dedicated lipid clinics. But I think in general, high-intensity statins reliably lower LDL cholesterol on average by 50%. So true statin intolerance is uncommon. I think the bigger issue that we face is when statin therapy alone is insufficient to achieve the desired LDL cholesterol, right? When we need additional tools from our toolbox to get our patient's lipid profile the way we want it. And that's really what we'll be tackling together this morning. So a couple things we'll go through. What we have learned from Fourier and Odyssey outcomes, not only the primary analysis, but also some key secondary analysis that have come out, especially with an eye towards risk stratification. Then thinking about LDL cholesterol targets in light of the brand new guidelines that just came out yesterday morning. And then lastly, all that's great for the theory, and then there's the practice of how do we actually get the drugs to our patients, and that'll be the third talk. We have worked hard to put in some case scenarios throughout the presentations at relevant points, paired with some analysis of the latest evidence to really sort of put the whole package together. Okay, so with that being said, it's my pleasure to introduce Michelle O'Donoghue, a senior investigator with us at the TIMI study group and associate professor of medicine at HMS. Michelle?
So just setting the stage, as Mark alluded to, I'm going to be reviewing some of the data from Fourier and from Odyssey. And as we think about the data that we have to date in regards to the LDL hypothesis, as we think about where we've moved to with the PCSK9 inhibitors, these are data from the cholesterol treatment trialists, and looking at the fact that consistently across different statin trials, but also importantly, regardless of how we're getting there, so if we look at non-statin lipid-lowering therapies, overall we're seeing that there's approximately a 22% reduction in coronary events per 1 millimole reduction in LDL cholesterol. This slide is now looking at similar concept, but looking at genetic variants that influence LDL cholesterol. So if you look at the x-axis here, you're looking at smaller incremental changes, at smaller absolute changes in LDL. But these are experienced over somebody's lifetime. But they've really afforded us the opportunity to learn quite a bit about the relationship about LDL cholesterol and the risk of coronary events. And here, for people who have these genetic variants, we see that the CHD risk reduction per 1 millimole reduction in LDL cholesterol is even larger because, again, this is a lifetime exposure to lower degrees of LDL cholesterol. And here it's a 54.5% reduction in CHD. You'll note here that a couple of the genetic polymorphisms that we're talking about are PCSK9 related. And that really sort of set the stage. This slide is just talking about the discovery of PCSK9 and its role in setting LDL cholesterol levels in humans about 15 years ago. And it was a very interesting discovery pathway, but notably they discovered that there was a mutation in PCSK9 that led to higher LDL cholesterol levels and to autosomal dominant hypercholesterolemia. So affected family members had a total cholesterol concentration in the 90th percentile. There was early exhibition of different forms of high cholesterol, including tendinxanthomas, as well as early manifestations of coronary heart disease, including early MI and stroke. So we knew that gain-of-function mutations in PCSK9 caused high levels of LDL cholesterol, and on the flip side, loss-of-function mutations in PCSK9 had the opposite effect, leading to lower rates of coronary heart disease and lower concentrations of LDL cholesterol. So that brings us to where we are with the PCSK9 inhibitors that were developed in response to some of these discoveries. And first I'll be reviewing the data from Fourier. Fourier was the phase 3 trial of evolocumab. So this is a very large trial. So we're looking at more than 27,000 patients who were enrolled. These were high-risk patients with established cardiovascular disease. These were patients with prior MI, prior stroke, or symptomatic PAD. These were individuals who were also on a high or moderate intensity statin therapy as background, with or without ezetimibe. They had an LDL cholesterol greater than 70 or non-HDL cholesterol greater than 100 at entry. They were randomized to either evolocumab or placebo and followed for a median of about 2.2 years. We'll talk a little bit more about the duration of follow-up as we move along. So overall in Fourier, we saw really a profound reduction in LDL cholesterol. Mark had talked about how with maximal statin therapy, you can see about a 50% reduction in LDL cholesterol. Here with evolocumab, there was a 59% mean reduction in LDL cholesterol. So starting with an average of about 90 in the Fourier trial, that brought folks all the way down to an achieved median of 30. So really when you think about your own practices and where you're trying to drive LDL cholesterol concentrations, it's really quite remarkable how low the LDL cholesterols were achieved within the PCSK9 inhibitor trials. And we'll talk a little bit further about how low do you go and whether or not there seems to be any kind of inflection point with not seeing any further benefit when you go down lower. So these are the top-line results of Fourier. Primary endpoint was significantly reduced with evolocumab by 15% as compared with placebo. There's a broader composite of cardiovascular death, MI, stroke, hospitalization for unstable angina, or coronary revascularization. When we look at the key secondary endpoint, the so-called harder composite, triple composite of cardiovascular death, MI, or stroke, here we saw a 20% relative risk reduction with evolocumab as compared with placebo. You'll note here that, and we'll discuss this a little further on the upcoming slide, but when you look at the pattern of where these curves begin to separate, they begin to separate early on, but you'll notice that they continue to diverge over time. So we think, as with many lipid-lowering therapies, that it does take some time to see the benefit. So as I alluded to, this is the landmark analysis. On the left-hand side of the screen, you're looking at the first 12 months of treatment with evolocumab within Fourier. Now on the right-hand side, you're looking at beyond 12 months. So you can see that there does appear to be a benefit early on. The curves start to diverge around 3 to 6 months. There's a 16% relative risk reduction in cardiovascular death, MI, or stroke. But you can see that that appears to be more pronounced over time. Beyond 1 year, you're now looking at a 25% relative risk reduction in cardiovascular events. So as you'll recall, the median follow-up for Fourier was 2.2 years. Had the trial gone longer, we anticipate that we might have seen an even larger benefit over time. These are now data from Odyssey. So this is the other PCSK9 inhibitor that's available, alirocumab. And they started with about a similar LDL cholesterol as what we saw within Fourier, so around baseline LDL of about 90 milligrams per deciliter, give or take. And as with evolocumab, there was a profound reduction in LDL cholesterol. If you look first at the on-treatment analysis, you can see that there was a sustained effect in LDL cholesterol over time. You can see that within the intention to treat, the ITT population, there was some perhaps very soft waning of effect in terms of LDL cholesterol reduction over time. But importantly, when you look at those patients who were on treatment, we don't see any waning of effect. This is relevant as there has been some discussion with one PCSK9 inhibitor in particular, bococizumab, regarding the development of anti-drug antibodies that may attenuate some of this effect. But we're not seeing that with evolocumab or alirocumab. Here we see a sustained effect in LDL cholesterol over time. So the top line results of Odyssey outcomes. Here there was again a 15% relative risk reduction in MACE, the primary endpoint of the trial, translating into a 1.6 absolute risk reduction. I didn't comment on the absolute risk reduction for Fourier, but that was a 2% absolute risk reduction. But notably within Odyssey, what they also observed was a significant reduction in all-cause mortality. Really quite remarkable for a lipid-lowering therapy to be able to demonstrate a reduction in all-cause death. So here there was a 15% reduction in all-cause mortality. As we saw with the Fourier trial, these curves take some time to diverge. In fact, when you look at the pattern of these Kaplan-Meier curves, you're really not seeing any kind of separation of the curves before about 1.5 years. So there was a 0.6% absolute risk reduction in all-cause death within the Odyssey program. Now, what about different subgroups? Are there particular patients who appear to benefit more from PCSK9 inhibitors? And I'll be delving into that a little bit further in upcoming slides. But broadly speaking, when you just take a quick look at either the primary endpoint or the key secondary endpoint for Fourier, you can see that overall there appears to be consistency. You're seeing many of these point estimates basically lining up. We'll discuss a little bit further about baseline LDL cholesterol. Here within Fourier, you can see that regardless of whether or not you were starting with a low baseline LDL cholesterol or a higher baseline LDL cholesterol, the treatment benefit appeared to be very consistent. So again, the key secondary endpoint being cardiovascular death, MI, or stroke. Regardless of whether or not people were on a background of intensive statin therapy, whether or not they were on the background of ezetimibe, we were seeing very consistent results across all these key subgroups. This is now a similar slide, but now looking at Odyssey outcomes, so alirocumab. Here again, we saw consistent results in terms of the overall relative risk reductions that we were seeing across key subgroups, including age, sex, region, as well as basically from the time from the index event. Notably, there has been some discussion about the fact that when you look at baseline LDL cholesterol and the relative benefit of alirocumab, depending on where your LDL cholesterol started, you can see that even though the p-value was not significant, there was a bit of a trend towards there being a larger relative risk reduction for those who started with higher LDL cholesterol. But we'll be coming up a little bit later to some data, sort of pooling the data overall, to suggest that it appears that really regardless of where your LDL cholesterol starts, there appears to be consistent benefit. What about diabetes? Well, we certainly know that diabetes dials up your risk. And as a result, within Fourier, when you look at the absolute risk reduction, and as a consequence, the number needed to treat, it was smaller for individuals, so the number needed to treat was smaller for individuals who had established diabetes. So on the left-hand side, you can see that there was a higher event rate, and this translated into a larger absolute risk reduction of 2.7% as compared with 1.6% for those without diabetes, and a number needed to treat of 37 for individuals with diabetes as compared to 62 for those without. Data now from Odyssey, alirocumab, similar concept, looking at those who have normal glycemia, pre-diabetes, or diabetes. On the left-hand side here, we're looking at the relative risk reduction, which you can see was really quite consistent, regardless of whether or not individuals had diabetes. So there was no heterogeneity on the basis of the relative risk reduction. But when you look at the absolute risk reduction, again, speaking to the fact that if you have diabetes, this dials up your risk of having a cardiovascular event, there was a tendency towards a greater absolute risk reduction in a smaller number needed to treat for those individuals with diabetes who were treated with alirocumab. What about other factors that might help to identify those who derive greater benefit from a PCSK9 inhibitor? This is work done with, by our chair here, Mark Sabatine, looking at the time from the qualifying MI in the Fourier trial with evolocumab. So those individuals who are within 2 years of having had an MI, again, this is selecting a higher risk group, so they had a higher rate, background rate of cardiovascular events, but also tended to have a larger relative risk reduction and a larger absolute risk reduction when treated with evolocumab. So you can see that those individuals who were more recent from the time of their MI had a 24% relative risk reduction when compared to a 13% relative risk reduction for those who were further out. Also, if you look at those individuals who had had more than one prior MI, so you can imagine, again, this is another way to help identify higher risk individuals. And for those who'd had 2 or more prior MIs, there was a 21% relative risk reduction with evolocumab as compared with placebo. And you can see that there's really a marked jump up in terms of the event rate for these individuals, really nearly a doubling of the background event rate, which helped to translate into a lower number needed to treat of 38. Similarly, if you look at those individuals who have a history of multi-vessel disease, so those who had disease in more than one coronary vessel had a 30% relative risk reduction in cardiovascular events as compared to 11% for those individuals who did not have multi-vessel disease. Here there was significant heterogeneity between these groups. The number needed to treat, the delta between these two groups is really quite notable. So 29 was the number needed to treat to prevent one cardiovascular death, MI, or stroke for those with multi-vessel disease, as compared with 78 for those without. So as alluded to, we have a few cases that have been built in. This is a case of a 60-year-old woman who has PAD, type 2 diabetes. We've talked a little bit about the data for type 2 diabetes, and LDL cholesterol of 105 despite high-dose statin therapy. So delving a little more into the past medical history, Carol has left leg pain with ambulation. Symptoms occur with prolonged walking, described as cramping in the calf and thigh. She has a history of the hyperlipidemia, the type 2 diabetes, and you can see her medicines listed there. Notably, she's already on atorvastatin 80 milligrams. Despite being on maximal statin therapy, her LDL cholesterol is 105, her LDL is 45, and her A1C is 7.2%. So what do we do for our patients who have PAD? What therapies might be available to reduce subsequent events? Well, if we look at the data from Fourier, so in Carol's case, she has PAD, it is symptomatic. We know that PAD certainly identifies higher risk individuals. So if you look towards the top of the slide, these are individuals who have a background of PAD within the Fourier trial. They had a higher risk of cardiovascular events, this is cardiovascular death, MI, or stroke, and a larger absolute risk reduction, so 3.5% absolute risk reduction. So you only needed to treat 29 patients with PAD to prevent one cardiovascular death, MI, or stroke event. In contrast, those who did not have PAD had a lower event rate and a higher number needed to treat. Well, that's cardiovascular events, but what about actually reducing PAD events? So this is the outcome that people are starting to refer to as MALE, major adverse limb events. You can see that there was really a marked reduction, which is very exciting because we really don't have a lot of therapies available to help reduce the risk of actual PAD events for our patients who have PAD. So you can see towards the right on the table at the bottom, when we look at acute limb ischemia, major amputations, all of these were really quite dramatically reduced. About a 55% relative risk reduction in major amputations. And these are outcomes that are obviously meaningful for our patients with PAD. So we can discuss the case a little bit further later on, but as we think about an individual like Carol, who's already on maximum statin therapy, we can consider different options. One would be the addition of ezetimibe. We'll be talking a little bit further about the updated guidelines. But then certainly if they're still not where we think that they should be, the addition of a PCSK9 inhibitor may be very appropriate for our higher risk patients. So here's another case. Ben, 54-year-old male with a history of MI and an elevated Lp(a) on high-dose statin therapy. He has a past medical history of an inferior ST elevation MI. He had a stent placed to his RCA 10 months ago, so really quite close in time to his most recent MI. He has a residual lesion in his LAD, hyperlipidemia. He's currently on maximal statin therapy in regards to rosuvastatin 40. And his LDL cholesterol, some people would consider that to be relatively well controlled, 75. Hopefully we'd be trying to get those LDL cholesterol concentrations even lower. But one thing that's also causing some concern is he comes to you and he says, but hey, I've been hearing about this Lp(a). And you find out that his number is really quite elevated, so 200 nanomoles per liter. So that would really place him in the top quintile of individuals with Lp(a) concentrations. And we know that Lp(a) appears to play a causal role in atherogenesis. We know this based on Mendelian randomization data. There's a lot of research that's still ongoing. In fact, some data were presented yesterday looking at new therapies that might help to lower Lp(a). But to date, we actually have relatively few therapies available. In fact, some of the data suggest that statins might actually raise Lp(a). So one of the exciting developments with the PCSK9 inhibitor class is that it does appear to offer a significant reduction in Lp(a) concentration. So specifically, if we look at data from the Fourier trial, this is the change in Lp(a) from baseline to week 48 with evolocumab. There was about a 27% reduction in Lp(a), which translated into an absolute change of about 11 nanomoles per liter in Lp(a). This is a scatter plot looking at the change in Lp(a), the absolute change in Lp(a), versus the change in LDL, specifically for patients who were treated with evolocumab within the Fourier program. It's really bringing home a fairly simple concept. We would have thought intuitively that there'd be a very strong correlation between the drop in LDL and the drop in Lp(a). But it turns out when you look at the correlation coefficient, it's only 0.21. That's only modest at best. There are people who are falling in these discordant categories. So namely people who are actually having limited or no effect on their LDL, but having a large effect on Lp(a) and vice versa. So it's intriguing. This is an area of further research to understand, through what mechanisms and pathways we're seeing these changes in Lp(a) with the PCSK9 inhibitor class, and why the correlation does not always appear to be very strong. Well, what about Lp(a) in terms of predicting the benefit of PCSK9 inhibitors? There's a lot of interest, as you know, in trying to identify higher risk individuals who may benefit more from PCSK9 inhibitor therapy. These were data from Fourier, where we stratified individuals based on their Lp(a) at baseline, so whether or not they were above or below the median. And we found that for individuals who had an Lp(a) that was above the median, that they appeared to derive enhanced benefit from treatment with evolocumab. So on the right-hand side of the screen, these were these higher risk individuals, and they had about a 23% relative risk reduction in coronary events, as compared with really only a marginal reduction for those who had a lower Lp(a) at baseline. So the number needed to treat was 40 to prevent one CHD death, MI, or urgent coronary revasc event, as compared with 105 for those with an Lp(a) that was below the median. So there's a lot of interest in whether or not that might be one high-risk feature to help identify patients who will derive enhanced benefit. And so looking at sort of a concept of dual goals. Well, we think a lot about LDL cholesterol and trying to get those numbers down, but what about if somebody still has an elevated Lp(a)? That's what this figure is looking at, is the achieved Lp(a) and achieved LDL and subsequent cardiovascular risk. Within the Fourier trial, if you had an individual who had high levels of Lp(a) and LDL cholesterol despite being enrolled in the study, they had a high subsequent risk of cardiovascular events at 3 years. But when you look at the blue or the maroon categories, these were individuals who had only achieved one of those two goals. So either an LDL cholesterol below 70 or an Lp(a) below 120, which is 50 milligrams per deciliter. They had intermediate risk. But those who were at lowest risk, when you look at this red stacked bar, these were the individuals who were at lowest risk. So supporting this concept of dual goals, whether or not we should be thinking not just about LDL cholesterol, but trying to drive down individuals' Lp(a). So I'd alluded to at the beginning was, how low do we go? You know, do we really target an LDL cholesterol value? And it's challenging, and certainly we'll have more of a discussion in that regard when we think about the guidelines. But within FOURIER, if you look at the data, the x-axis is looking at the achieved LDL cholesterol at 4 weeks, and the y-axis is looking at the adjusted event rate. And as you can see, when you go down to lower and lower achieved LDL cholesterol concentrations, you're seeing a very linear relationship in terms of event rate, in terms of risk. So what we're seeing is that no matter how low you're going down, these are now numbers that are as low as 19 here on the x-axis, you continue to have a lower rate of cardiovascular events. So we're not seeing any clear plateau in terms of how low you can go and further drive down somebody's CV risk. Well, what about the safety of achieving very low levels of LDL? I remember when these drugs were first being developed, there was a lot of concern about possible neurocognitive effects for getting down to those very low LDL cholesterol concentrations. But in fact, we actually didn't see any types of safety concerns within the FOURIER or ODYSSEY programs for those individuals who achieved very low concentrations of LDL cholesterol. So again, the blue here is looking at individuals who achieved an LDL less than 20. Which I think for a lot of our patients would certainly give us a little bit of pause, but we're really not seeing any safety concern, and we know that those individuals are at lower risk of cardiovascular events. This is now looking at patients who started with a baseline LDL cholesterol less than 70 within the FOURIER trial, so those who already had what many would consider to be already achieved an optimal LDL cholesterol. And you can see that there was a profound reduction in LDL cholesterol within those patients, a 66% mean reduction. And these individuals achieved a median of 21 milligrams per deciliter. And if you look at the interquartile range, it's notable that 25% of individuals were actually achieving LDL cholesterols less than 11.5. So you're talking about achieving now the single digits. And when you look at now cardiovascular event rates, both for the primary and the secondary endpoint, for individuals who started with a baseline LDL less than 70 versus those who were above, you are seeing very consistent benefit. So if anything, actually numerically, the hazard ratio is even greater for those who had a baseline LDL less than 70, and similarly a larger relative risk reduction in cardiovascular death, MI, or stroke on a numeric basis. And if you combine data across the different programs, so we discussed a little bit about how in ODYSSEY there was a suggestion of whether or not people with higher baseline LDL cholesterols might derive enhanced benefit. But when you look at the weight of the data, so this is combining data from the statin trials, so the cholesterol treatment trialists, IMPROVE-IT, FOURIER, REVEAL. If we take those individuals who had a baseline LDL cholesterol less than 70, we are seeing very consistent benefit. We're seeing, you can see here that overall, when you combine these different point estimates, you have a 21% reduction in major vascular events per 1 millimole reduction in LDL cholesterol. So in conclusion, for my section of the talk, we know that PCSK9 inhibitors have emerged as a very potent therapy. They reduce LDL cholesterol by about 60%, and this effect for evolocumab and alirocumab appear to be sustained with time. They significantly reduce cardiovascular events. And again, we saw those curves diverging. The longer patients are treated, it appears that they derived enhanced benefit. So I discussed some of the different patient groups who may derive some enhanced benefit. There's a lot of interest in Lp(a) and whether or not this might be a helpful marker for identifying patients who also derived enhanced benefit. So from there, I'll pass on the baton for more of a deep dive on the discussion of the new guidelines and additional data as well. Thank you.
So that was great. Before the baton is passed, so we've had some great questions that came in. We want to make sure we just tackle them while we're in sort of the relevant section. So, so the first question we got from the audience, for Odyssey outcomes, the graph you showed, one person said, well, it looks like there's a waning effect. When the trial started, Fourier and Odyssey outcomes had slightly different approaches. In Fourier, we just sort of gave them the maximum dose and sort of had faith that it would be effective and be safe. In Odyssey outcomes, there had been, based on some earlier data from the program, some concern for some side effects for very low LDL cholesterol. Turns out that there were no issues for that. But the way the trial was designed was that if your LDL got too low, then they would decrease the dose. So there was dose titration between the 75 and the 150 in terms of whether you'd be up titrated or down titrated or come off to try to keep patients roughly in the sort of the 25 to 50 milligram per deciliter range. So that meant that individuals who started at the lower end then oftentimes would, we don't know the exact numbers, but would be down titrated. So I wouldn't worry about that graph that alirocumab has some waning effect over time. There was a very small proportion with neutralizing antibody, but it was tiny. I think that's just a function of the trial design. So that was one question. Second question was, are PCSK9 inhibitors better without a statin? There's looking at some of the subgroup plots.
No, overall, we're seeing that there appears to be consistent benefit regardless of background of statin therapy. And certainly we'll be discussing further that we do recommend that individuals be maximized on statin therapy whenever possible before the addition of a PCSK9 inhibitor. But certainly there are individuals who may have, quote unquote, statin intolerance, and of course many still debate what that exactly means. But we're seeing consistent benefit in regards to the benefit of a PCSK9 inhibitor.
Yeah, no, I think that's true. And the other point, just it's for individuals who can't tolerate a statin, their LDL cholesterol levels will be very high. So the absolute reduction in LDL cholesterol will be really big with a PCSK9 inhibitor. So if they're running with an LDL cholesterol of 180, then dropping that by 60% drops you by about 100 milligrams per deciliter, which is about 2.5 millimoles. So that's a really big delta versus someone who's on a statin, they're 90, you're going to see about half that. But the relative risk reductions are the same. Well, that's my pleasure to ask Dr. Robert Rosenson from Mount Sinai, where he's the director of cardiometabolic disorders, to come up and talk to us about an incredibly timely topic for following the direction of consensus recommendations and guidelines.
Certainly a very exciting era in lipid-lowering therapy. And I'll be addressing some of these issues in the new guidelines, some of the controversies, and what can we learn more from the data that's available then presented in the guidelines, a process that takes years to develop and really a living document influenced by clinical trial data. There are several guidelines for cholesterol lowering, and we review the ESCAS guidelines that recommend for individuals at very high risk for a cardiovascular event to reduce the LDL cholesterol to less than 70 milligram per deciliter or a 50% reduction in LDL cholesterol. The American College of Clinical Endocrinologists identified people at extreme risk, focused very much on the diabetes population, but recommended a more aggressive LDL cholesterol target of less than 55 milligram per deciliter. In the ACC expert decision pathway, they address the issue of combination therapy, and unlike the previous guidelines from 2014, presented in 2013, they incorporated a reduction in LDL cholesterol of 50% or more, but incorporated this target of less than 70 milligram per deciliter. So you're starting to see some of the change in the evolution of the ACC AHA guidelines, percent reduction, as well as a minimal acceptable target. In individuals who have atherosclerotic cardiovascular disease and comorbidities, who are receiving high-intensity statins, who have a 50% reduction in LDL cholesterol or maybe less, and have an LDL cholesterol less than 70 or a non-HDL cholesterol less than 100 milligram per deciliter, what do we do? Well, the issue of combination therapy has been shown to provide incremental benefit with ezetimibe in the IMPROVE-IT trial, about 7 years, 2% absolute event reduction, and then the Fourier study, after 2.2 years, there was a 2% absolute benefit. So the use of a more potent LDL cholesterol lowering agent provides greater benefit in a shorter period of time, as one would expect. And this whole controversy about whether you start ezetimibe or PCSK9 is something that is relevant, and I hope to receive your input today, because some of the metrics need to be reconsidered, particularly in a high-risk individual who has a substantial increased risk for a recurrent cardiovascular event, and whether you take a strategy to lower LDL cholesterol aggressively with a proven therapy, PCSK9 inhibitor, derive the benefit in 2 years versus something that's less effective on LDL cholesterol lowering that takes 7 years to achieve the same absolute event reduction is one that we need to debate. And the whole issue of economics is important in this discussion, and the guidelines presented yesterday were cautious in that regard, but there have been changes in the price structure of the PCSK9 inhibitors, which is going to mandate that some of these decisions be re-evaluated. So these guidelines on, from the American College of Cardiology for non-statin therapy are identifying people with atherosclerotic cardiovascular disease without complications as well as with complications, and are recommending that 50% reduction in LDL cholesterol. If they fall short of that, or they have an LDL cholesterol over 70 milligram per deciliter, they recommend ezetimibe first, followed by a PCSK9 inhibitor second. On the below the red line here are individuals who are at risk for cardiovascular disease, who have less than a 50% reduction in LDL cholesterol or an LDL cholesterol greater than 100 milligram per deciliter, and they're considered for ezetimibe or a bile acid sequestrant, and then ezetimibe or a bile acid sequestrant, for individuals who have a different risk but a high LDL cholesterol. Many of those individuals have familial hypercholesterolemia. So there was a lot of unclear, guidance as to who were the very high-risk populations. We learned some of this information yesterday, guided in large part by Fourier analysis as well as observational cohort studies. One of the other major advances of the guidelines yesterday were more description about primary prevention strategies, which were not as well defined in previous guidelines. So focusing on the individual with very high-risk atherosclerotic vascular disease who's on high-intensity or maximally tolerated statin, who has an LDL cholesterol greater than or equal to 70 milligram per deciliter, adding ezetimibe was considered reasonable as a first step. If PCSK9 inhibitor is considered, they're recommending ezetimibe first. One of the problems I had with that recommendation is that this was not a mandate in either Fourier or Odyssey outcomes that one had to be on a high-intensity statin and ezetimibe before going on to a PCSK9 inhibitor. And the use of ezetimibe in Fourier and Odyssey outcomes was only a few percentage of those individuals. So this is a divergence in guidelines versus what the clinical trial data, design and baseline characteristics, showed. And again, the issue is about cost, accessibility, but again, this dynamic is changing. So the point is that all of these guidelines are recommending that we focus on percent reduction as well as the target. Again, is the target of less than 70 milligram per deciliter adequate for some of the very high-risk individuals? And this is a topic that I'd like to discuss in a moment. So we had an opportunity to write an invited review for the Journal of the American College of Cardiology on an update on PCSK9, working off the very elegant work from Mark and Bob Giuliano, who wrote a paper on the state of the art for PCSK9. And we filled in some of the gaps that were learned from the randomized clinical trials that were completed during that time. We identified individuals post-ACS as a very high-risk population, people with coronary disease and hypercholesterolemia. We recommend following the ACC/HA guidelines to optimize statin therapy, the high-intensity statins. And if the LDL cholesterol is less than 70 milligram per deciliter, we want to monitor those individuals for treatment adherence, encouraging lifestyle changes, which are very important, and monitoring for the development of other risk factors. If the LDL cholesterol is greater than or equal to 70 milligram per deciliter, we recommended the use of ezetimibe. And if the LDL cholesterol level remained greater than or equal to 70 milligram per deciliter, we recommended a PCSK9 inhibitor. The big divergence in our recommendations from the ACC/HA guideline that was presented yesterday is that we identified some very high-risk individuals who we recommended an LDL cholesterol less than 50 milligram per deciliter. Where did this number come from? Well, the IMPROVE-IT trial titrated up with ezetimibe if the LDL cholesterol was 55 milligram per deciliter above, and then the ODYSSEY outcome study intensified the alirocumab if the LDL cholesterol was greater than or equal to 50 milligram per deciliter. So those two trials provided a titration looking at more intense LDL cholesterol lowering, and so we felt that some of these very high-risk individuals, based on clinical trial data, might benefit from more aggressive LDL cholesterol lowering. It'd be very nice to see some analysis from FOURIER that looks at some of these thresholds. Clearly, we know from the FOURIER trial, the lower the LDL cholesterol, the lower the event rate, and it's very safe to lower LDL cholesterol even into the single digits. So we have a patient, Henry. He's 50 years of age, an African-American male, and he had a prior myocardial infarction about 2 years ago. His LDL cholesterol on high-intensity statin is 72 milligram per deciliter. So the MI, it's not less than 2, it's about right at 2. Coming back for that visit. He's on rosuvastatin at a 40 milligram dose and takes multivitamin daily. What about the rest of his lipid panel? Well, his HDL cholesterol is above average for a man. Triglycerides are slightly above 150. The lipoprotein A is right at the 90th percentile, 75 nanomole per liter. The guideline presented yesterday identified a high-risk category for an LPA of 125 nanomole per liter. So he falls short of that, but he's still at the 90th percentile. And one needs to consider that this is a markedly skewed distribution for LPA, number of 75 is not inconsequential. So let's ask some questions. What is the risk of recurrent atherosclerotic cardiovascular events in patients treated with high-intensity statin? Is high-intensity statin therapy enough, as Rod Hayward suggested in his systematic analysis in the Annals of Internal Medicine? That was, in large part, what influenced the last set of guidelines. Or are there other factors in patients who had a prior myocardial infarction that may influence the risk? Certain behaviors, certain angiographic characteristics, multi-vessel disease, and we heard a very nice presentation from FOURIER that identified some of those groups. What other major risk factors? Cigarette smoking, uncontrolled hypertension, diabetes. How does that influence the risk? And what's the effectiveness of more intensive LDL cholesterol-lowering therapy to reduce a recurrent cardiovascular event? Well, we had an opportunity to conduct this analysis in Medicare and MarketScan in individuals, and we looked at individuals who had an MI who underwent PCI. We identified a optimal treated population. These were individuals who had prescribed antiplatelet therapy, who were on beta blocker, were on ACE and ARB, and high-intensity statin, which was defined as atorvastatin greater than or equal to 40 milligram daily, or rosuvastatin greater than or equal to 20 milligram daily. Why did we pick those doses? Because we looked at Medicare population, many individuals over 75, and those are the recommendations in the last set of guidelines, is to use a half dose due to the potential concern of drug-drug interactions and impaired metabolic pathways, liver and kidney. So in this study, we compared several populations. So first of all, we have the intensively medically managed post-MI patients, general population, patients without clinical cardiovascular disease and diabetes, in patients who had prior coronary disease but no prior myocardial infarction. But I just want to point out some of the rates for recurrent MI. These are in people who already had a myocardial infarction. So compared to the general population, individuals who had a myocardial infarction optimally treated had a 10-fold higher risk of a recurrent myocardial infarction. Compared to individuals with diabetes in the general population, the risk is almost doubled. In individuals who have coronary disease, compared to the general population, the risk is more than doubled for having a myocardial infarction. Hospitalization for coronary heart disease events are also increased compared to the general population over here, and individuals with diabetes have a higher risk than the general population, as do people with prior coronary disease and no MI. But these individuals who have had one myocardial infarction remain at substantially increased risk. Mortality was higher in people who have an MI compared to the general population, despite implementation and high adherence to evidence-based therapy. High adherence defined as greater than or equal to 80% of their fills over a year's period of time. And mortality, interesting in the diabetes population, higher in those with coronary disease, tended to be higher. This is a multivariate adjusted risk for events, and extensive adjustments as shown here, including chronic kidney disease, statins. And compared to the general population, the risk of a recurrent MI is increased 8.5-fold in people that had one myocardial infarction. And this number is very similar to the observational data from Framingham that was published by Couples in the early 1980s, that showed that people with an MI had an 8-fold higher risk of myocardial infarction. So despite the implementation of evidence-based therapies, once you've had a myocardial infarction, the likelihood you're going to have a recurrent event is substantially higher compared to people that never had a coronary heart disease event. These rates are also higher in individuals with diabetes compared to the general population, as well as people with coronary disease. Moving down to hospitalizations for coronary disease events, we're seeing more admissions to the hospital compared to the general population, people that had an MI, as you are for people with diabetes, as well as people with coronary disease. And mortality rate is higher in individuals who had an MI compared to the general population, not significantly higher in people with diabetes and those who had coronary heart disease. So what this information says is that we need to do the right thing, proven by clinical trials, implemented by or recommended by guidelines, antiplatelet therapy, beta blockers, ACE/ARB, high-intensity statins, but it may not be sufficient. And this type of information, this real-world information, should really help guide some of our decisions and impact on the guidelines. Now, I want to just focus on the individuals who had a myocardial infarction. People who have multiple risk factors, who had a prior MI or atherosclerotic cardiovascular disease, require more intensive LDL cholesterol-lowering therapy, but there was no guidance as to what those risk factors were. We know that people with atherosclerotic vascular disease have risk factors, such as hypertension, one of the factors listed, are often cigarette smokers. So in our analysis, individuals who had a myocardial infarction, who had prior evidence of coronary disease, had a doubling in the risk for a myocardial infarction. People with prior MI who have diabetes, a doubling in the risk for recurrent myocardial infarction. Chronic kidney disease, a very important risk factor. Not prior stroke, and people with prior heart failure had almost a doubling in their risk for recurrent myocardial infarction. And so it was very gratifying to see the ACC-AHA guideline yesterday that identified high-risk population with diabetes, chronic kidney disease, and prior heart failure. These are the individuals we really need to focus upon, and again, whether an LDL cholesterol under 70 is going to be sufficient when the risk is doubled in those individuals compared to people without those enhanced risk factors is, I think, something that we're going to be debating in the days, weeks, and months and years to come. So this is, again, going back to our recommendation for more intensive LDL cholesterol lowering in those individuals, less than 50 milligram per deciliter. Now, in my second case is a woman who's at risk for cardiovascular event. She has an untreated LDL cholesterol of 254 milligram per deciliter. And to put that into context, is that her mother has hypercholesterolemia treated with a statin, experienced a stroke at the age of 60 years, but has cognitive impairment. So the patient is very concerned about being placed on a statin because she's heard that statins cause cognitive impairment. Of course, the FDA reviewed this data, and there's no clinical trial data to support these reports. And of course, a very detailed analysis in the Ebbinghaus would show that at least lowering LDL cholesterol to low levels is not associated with impairment in cognitive function. But this is her concern, and which has precluded her from starting statin therapy at the time of the encounter. Her father also has hypercholesterolemia treated with a statin. Importantly, her sister, another patient of mine, is 51 years of age. She's had 7 coronary procedures and stents. So our patient became a vegan, thinking that this was going to take care of the genetic risk that she had. Now let's move back over to the lipid panel. She not only has high LDL cholesterol, but a very high lipoprotein A level, and also a high level of the atherogenic lipoproteins, the ApoB-containing lipoproteins. So certainly high-risk individual who's vegan. Now, it's also important to say that on a vegan diet, her LDL cholesterol fell 100 milligram per deciliter. So I'm not in any way diminishing the importance of a strict low-fat diet. It does work, but it may not be sufficient in people with genetic hyperlipidemias. In this analysis from Norgestad, of course, it's basically reiterating the message that Michelle talked about before in terms of genetic association between LDL cholesterol events. Individuals who are of homozygous familial hypercholesterolemia have the highest risk for coronary heart disease events starting very early in life. Patient with one defect, the heterozygous FH, are more of an intermediate risk, but substantially much higher than people without this genetic trait. Why? Because the exposure has been there before they were born. The concentration of LDL cholesterol has been accumulating for their lifetime. The question is, with the use of statin therapy and some of the newer therapies we have available, can we reduce the risk for a myocardial infarction in these individuals to the same as somebody who doesn't have this genetic trait? And there's data from the Spanish FH network that shows that early treatment can actually lower the risk substantially and reduce the risk such that it's not higher than individuals who have not had an event. So an early treatment strategy is important. I think the pediatric part of the guidelines presented by Sarah DiFerente were a very important addition to these guidelines. So our patient decided that she was going to accept the recommendations for high-intensity statin therapy, atorvastatin 40, ezetimibe 10, and the repeat lipid panel shows an LDL cholesterol 110 and an LPA of 218 nanomole per liter. So the question is, what other diagnostic studies may be useful that may influence further treatment? Would you perform a stress test on her, coronary calcium score, lower extremity arterial Doppler, or maybe you're of the opinion that additional diagnostic studies would not influence your management? So again, she was very concerned about cholesterol-lowering therapy. Cognitive impairment was very focused on this issue as her mother's health has deteriorated, and she wanted evidence that she actually had coronary disease and should stay on this therapy despite the fact that her sisters had so many events. And the coronary artery calcium score was at the 99th percentile. So again, extensive coronary disease, vessels. The lesions were 25 to 50%, not necessarily causing symptoms, but certainly she's at risk. And one of the very important advances in the guidelines yesterday were the use of coronary artery calcium scoring to help guide some decisions in people that are concerned in that physician-patient interaction or individuals where the risk decision is not as clear. We know that coronary calcium increases in patients with familial hypercholesterolemia, age-related. It's very prevalent. In our example, in our patient showed the higher risk. What we recommended to our patient is actually to start a PCSK9 inhibitor. The LDL cholesterol of 110 milligram per deciliter exceeds the recommendations from yesterday of 100 milligram per deciliter. And so this woman who was very concerned about LDL cholesterol lowering therapy all of a sudden became concerned with the coronary calcium score and then the CT angiogram that showed that she has multiple stenosis, albeit 25 to 50% in multiple vessels. So to conclude, the efficacy of LDL cholesterol lowering therapy in high-risk patients treated with PCSK9 inhibitor or candidates for PCSK9 inhibitor are influenced by many disease factors, as we heard: time after the MI, the number of MIs, multivessel disease, multivascular disease. Certain clinical factors, diabetes, chronic kidney disease, also a very large impact in individuals who have a prior MI. And we also should consider the people that are at risk, the family history, as well as maybe the need for non-invasive testing in people that feel that the diet is so good they don't have to worry about the risk, despite the background of a strong family history and genetic traits such as heterozygous FH. Thank you very much.
So we're going to start with our case. 63-year-old Hispanic male. History of type 2 diabetes, well managed with metformin and a GLP-1 agonist. Former smoker, stopped after his first myocardial infarction 1 year ago. And we know that people often have dramatic risk factor modifications after an event like that. Recently discharged from the hospital after a second MI. He was taking atorvastatin 80 milligrams at the time of the first MI. People often are discharged, obviously, on high-dose statins, and thankfully he stayed on it. But he had to have it reduced to 10 milligrams due to the development of severe muscle-related complaints. So on discharge this time, ezetimibe 10 milligrams was added, and his LDL cholesterol is currently 85 milligrams per deciliter. So you prescribe a PCSK9 inhibitor based on the LDL cholesterol level being greater than 70 milligrams per deciliter in a high-risk patient, and I would tell you this is an extremely high-risk patient on maximally tolerated statin therapy with ASCVD, and it's denied. Is this an unreasonable scenario for anyone in the audience? I think we've all seen this at some point, and I want to talk to you a little bit about how we can improve this process. So I am an internist by training, a lipidologist in practice. I see patients in two settings: a private referral practice at NYU, and then also at Bellevue Hospital, which is an inner-city referral center for all of the other city hospitals in New York. And we obviously have a variety of different challenges in both of those settings. But when we think about the reasons why patients are not using high-intensity statin therapy, this is some great data published by Jerry Cohn in the Journal of Clinical Lipidology, reminding us that statin side effects or intolerance make up the majority of those reasons, followed by adherence and then patient preference for other treatments. High risk like this, and they want to talk to me about red rice yeast and niacin and coenzyme Q and a variety of other things rather than alternative therapeutic interventions that we know will reduce their risk of cardiovascular events. And as much as I'd like to believe in a referral lipid clinic, we're seeing inherited lipid disorders all the time. Statin intolerance and side effects from statins actually makes up the #1 reason people are referred to our clinic. And just to remind us, statins are important, statins are cheap, statins are safe, and they're effective in reducing the risk of cardiovascular events. And I don't need to belabor this point, but despite this fact, we're not doing well with regards to getting patients on appropriate doses of statins. And this is data from Pinnacle, a registry of cardiologists engaged in the practice of cardiovascular risk reduction through the American College of Cardiology. And you can see here in the boxed out circle on the left, just looking at ASCVD, never mind the diabetics or the patients with familial hypercholesterolemia, patients that are not on statin therapy in blue is nowhere where we'd like to see it. So we're not doing as good a job as we'd like, even in probably the best practices in engaged cardiology centers around the country. And we also know there's great rationale, both from the data Mark has published in Fourier and what we've seen in Odyssey, meta-analyses. You published a wonderful meta-analysis recently, and this is just some older data, again reminding us that getting to low LDL cholesterol levels is reasonable. And we look at the overall impact of PCSK9 inhibitors on lipid levels. Again, an LDL reduction of over 50%, at least consistency across the outcome trials and all of the enrollment trials. So this is an important tool that we need to be using as an adjunct to patients who either are on maximally tolerated statin therapy and are not at their LDL goal, whether it's less than 70, less than 55, or a 50% reduction in LDL cholesterol, or they simply can't take the appropriate dose or any dose of statin therapy. So what's the best approach for adding a PCSK9 inhibitor? And this is kind of shrouded in the background that we're not doing a good enough job with less expensive, well-documented, efficacious therapeutic interventions such as statins and ezetimibe, which are both generic right now. So this is a wonderful analysis from Chris Cannon. What he did was they actually looked at patients who were on a variety of different therapeutic interventions. High-intensity statin with ezetimibe, moderate-intensity statin with ezetimibe, high-intensity statin only, or ezetimibe only, and then said, what would happen if we actually moved the bar? All right, this is kind of computer-generated modeling system. So again, here what you're seeing that no statin or ezetimibe here makes up 46%. But if we could actually really try to do everything we can to take these patients and give them all the options possible, right? There are 7, maybe 8 available statins, depending on how you kind of think about them in the United States right now. And then we have ezetimibe, which we know from clinical trial data to have a side effect profile no different from placebo. I think if you actually really try to move these patients around the way they should, and again, this is just a computer-generated model, you can see here that the number of patients who actually get to their LDL cholesterol levels below 70 would be dramatically improved. And even with the addition, in this case of alirocumab, at either 75 or 150 milligrams, you can see here that theoretically only about 14% of these patients would actually require a PCSK9 inhibitor. So if we can actually do the job we should, the number of patients that need PCSK9 inhibitors should be reduced, and then we can focus on the patients we're talking about today, which are the high-risk patients who have the greatest benefit. And I think that creates a new dynamic in how we think about this. So what's the PCSK9 inhibitor prescribing information? A little different for the two medications, and I think that's based primarily on the lack of a publication for alirocumab with the Odyssey data. So they are going to present their data to the FDA, and I think you'll probably see a package insert update for alirocumab also, but as an adjunct to diet and maximally tolerated statin in adults with heterozygous FH or clinical ASCVD who require additional LDL lowering. These are LDL lowering agents, right? Evolocumab as an adjunct to diet and maximally tolerated statin, heterozygous FH or clinical ASCVD, homozygous FH, and then to reduce the risk of MI stroke and coronary revasc in adults with established cardiovascular disease. That's with or without statins, and that has nothing to do with LDL cholesterol. So again, slightly different indications for the two drugs, but both of them are very effective, safe LDL lowering agents. So despite this, access to PCSK9 inhibitors does remain limited. And again, this is variable and it's a changing target all the time. I think it's based on region, I think it's based on center, and I think it's based on who's prescribing it, what their skill is at actually getting these medications into the hands of patients. So here you see two different data sets looking at rejection rates. In one here, 83% of these are rejected offhand initially, with 57 rejected ultimately, approval more likely amongst those on high-intensity statin therapy and ezetimibe already. Here another data set, 45,000 PCSK9 inhibitor prescriptions, 79 rejected within 24 hours. 24 hours, boy, I can't even read my emails within 24 hours. And 53 rejected ultimately. They vary by payer type, no surprise. And again, 35% of filled prescriptions were abandoned at the pharmacy. Why? Probably because of copay issues, right? So there's a variety of different reasons people are non-adherent. There's primary non-adherence. They never pick up the prescription. And that's a big problem, especially when we exert a lot of time and effort trying to get these drugs filled. So this is, again, more data from that same article that Jerry Cohn published. This is a survey done of prescribers of PCSK9 inhibitors by the National Lipid Association, identifying where assistance is needed with regard to PCSK9 inhibitor approvals. And the insurance process improvement is listed as the number one, and I think we are seeing movement on that regard. Documentation, though, I think is number two, and this is a big issue. Despite the fact that we have EMR, it's only as good as what you put in it. So if you don't document that the patient has FH and what the criteria are, and that you've examined the patient, and they have a corneal arcus, so they have tendon xanthoma, then it doesn't matter whether or not you say the patient has FH. If it's not there, you're not going to be able to document the diagnosis. If you say the patient has ASCVD, whether it's clinical or otherwise, you have to be able to support it. Have they had an MI, a stroke, a revasc? Do you have a note documenting that? Have they had a bypass procedure? If you believe subclinical atherosclerosis is the reason you're trying to get this approved, I think you have to document why and how. So again, documentation is really the key to approval. And this is another wonderful article published in Circ Research just about a year ago, pointing out all of these features. And what I've done is not to belabor, I'm not going to go through this, but you can see the word document shows up over and over and over again. You really have to write down. So what I do in clinical practice is when I get to my summary note, when I've decided we're going to start a PCSK9 inhibitor, I make sure I've listed why the patient needs the drug. What is the guideline or the recommendation that supports that? What's their most recent LDL cholesterol? What do I expect to happen when I use the drug? And again, what are the sources of that clinical diagnosis? So these are the tips, I think, that do increase the likelihood of getting these medications approved. Clearly specify the diagnosis. FH, you have to support it. If you don't know all of the criteria, just download the app. It's a great app. It's called FH Diagnosis, and it makes it very easy to diagnose FH. Provide a detailed medical history. Physical exam. If the corneal arcus is before the age of 45 and they ever went to an ophthalmologist, it's probably in their chart somewhere and you can find it. Document the highest LDL, ideally off treatment. That may not be possible. Someone comes to you with an event and they've had a history of heart disease for a long time. You're not going to stop the statin to find out what their numbers were off their statin medication. But again, you may be able to find out if you go back and get old records and include recent lab tests. You know, it's interesting to me, if you look at the indications, non-HDL cholesterol is not in there. But non-HDL cholesterol was an enrollment feature of both Odyssey and Fourier. And it's in the current 2018 AHA-ACC guideline. So I believe that an elevated non-HDL cholesterol is another way you might be able to get these drugs approved. So leverage team members to manage the prior authorization process. This does not mean you need to have this extensive of a team. I do it with one receptionist, all right? So you don't need an entire team, but you can leverage the physician, the nurses, clinical pharmacists, nurse practitioners, or PAs, and medical assistants. Anyone can get involved in this process and help you, and there are a variety of outside sources, prescribing hubs that can also help with this. Train dedicated team members. If you actually do this, the success rate goes dramatically up. But there are some additional tools that are available to you. It's a wonderful article published by the American Society of Preventive Cardiology 2 years ago now. I was part of this document, and we actually provided a sample, uniform, prior authorization, and appeals level. And you can download this for free. It's a wonderful tool. You can find it down there in Clinical Cardiology in 2017. And I encourage everyone to look at this paper. The American College of Cardiology has a prior authorization reporting tool. ACC wants to know what your problems are. If they know what the problems are, they can advocate on our behalf to make the process more simplified and streamlined. And finally, the National Lipid Association, as a follow-up to providing actionable tools based on the survey I showed you, put together a prior authorization checklist. And you can also download this for free at lipid.org. So there are a variety of tools that are out there to help you move this process forward. So what about cost? Because I mentioned that not filling the prescription in the pharmacy is actually a significant reason that a lot of people are not adherent. And I think part of it has to do with the fact that in patients who have Medicare in the United States, there is a copay issue as they proceed through the year and the, quote, donut hole with regards to cost. And so this is a concern, and you can see from this data set that out-of-pocket costs can go up to $3,000, if not more, for some of these patients. And obviously, faced with significant copays, many patients don't want to even start the medication. But things are support copay. Both alirocumab and evolocumab have provided these programs. And I'm not going to go into the details, but remind you that they are available. And there are additional assistance for some patients, specifically based on how much they earn. But beyond that, we know that both evolocumab and alirocumab are now being provided at lower costs. This theoretically should translate to reduced copays, especially for Medicare patients as opposed to commercial payers. We've also been told that that's going to translate into more simplified attestation forms as opposed to the more complex prior authorization forms. And I think a lot of this is going to be worked into some of the stuff that Bob talked about, because I think not only is it the cost of the drug, but it's the cost of the drug for the particular patient. And identifying high-risk patients, not just ASCVD, but I would even tell you within the FH population, thinking about risk stratification is an area we're going to have to start thinking about how do we identify the patients that most benefit. So modeling costs with different regimens, this is some data from Salim Barani, and he just suggested that even in the VA system, when you first look at the potential patients that might potentially need PCSK9 inhibitors, the projected cost is over $2 billion. But if you actually titrate patients up, treat the patients that require it based on evidence-based guidelines, you can see that the costs come down significantly. So knowing and understanding risk, knowing and understanding guidelines, and knowing and understanding the data that we've now generated around these patients, I think allow us to better take care of these patients. So I'll finish up with our patient, who I remind you again, we prescribed the PCSK9 inhibitor and it was denied. But what we do now is document a trial of an additional high-intensity statin, LDL remaining greater than 70, and again, quote the guidelines and recommendations along with the package insert, and we should be successful. So again, with regards to the take-home messages, I'm not going to go through this, but I think it's important to remember that resources are available, team-based approaches, documentation, 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 and support and copay problems will make this a lot easier.
There are just a couple questions that came up. Some were legacy questions from Michelle's presentation. Which statins lower Lp(a)?
Yeah, so although the data are inconsistent, there's actually no clear evidence that statins lower Lp(a). In fact, many studies actually suggest that they raise Lp(a), the clinical consequences of which are not completely elucidated. But in terms of what therapies we currently have, aside from PCSK9 inhibitors that lower Lp(a), really primarily you're looking at niacin that has a sort of a marginal effect on reducing Lp(a). That's smaller than what we see with the PCSK9 inhibitors, and as you're likely aware, to date we haven't seen any clinical outcomes trial that suggests that the treatment with niacin actually translates into a lower risk of cardiovascular events. So
perfect. No, that's great.
Few options.
So someone pointed out that just to go back to the Odyssey outcomes curve, that even for those on treatment, it looked like the curve went up a bit. And so is there some attenuation of the benefit of alirocumab? But I don't think so. What happens in these trials is even for patients who say they're on the drug, they're not always on the drug. And it is possible that individuals then down titrate their statin without necessarily admitting that. So in general, I think for the PCSK9 inhibitors, if you're on it, you'll get a very consistent reduction, and there'll be a paper coming out on that in JAMA Cardiology in a bit. Rob, one point you had raised the 7 years. You want to just sort of talk about for improvement when you talk about an absolute risk reduction, how we need to know over what time period, maybe just to go over that again.
Yeah, so the IMPROVE-IT trial showed that after 7 years of treatment, there was a 2% absolute reduction in cardiovascular events. With more intensive LDL cholesterol lowering therapy in the FOURIER trial, a 2% absolute event reduction was seen at 2.2 years. So when you're considering somebody who's high risk for recurrent cardiovascular event, the MI patient who's got this enhanced risk profile, the question is about starting therapy with a PCSK9 inhibitor because you're going to get more benefit at a shorter period of time than you will with ezetimibe. And I think this is one of the issues that was not flushed out clearly in the guideline presentation yesterday. There was so much focus on cost, but not necessarily the science. And we identified in our analysis of Medicare and market scan, there are certain people that are at very high risk for recurrent cardiovascular event and compared to the general population have a higher death rate. And so we need to keep these issues in mind as we make decisions on behalf of our patients.
Yeah, no, I think that's perfect. And I have to say, I think for me, the guidelines were somewhat of a disappointment. I think, as you nicely put in your JACC paper, we know there's benefit from driving people's LDL cholesterol down. So in that sense, the target of 70 in the guidelines, if you're 71 and you start a PCSK9 inhibitor, you'll get a 60% reduction. That's roughly a 40-ish or so milligram per deciliter decrease in LDL cholesterol. That should translate long-term into a 25% relative risk reduction. So that's great, and you're getting the patient down below the target levels that you had nicely put there. I worry that if someone's at 69, then you're not doing anything, and their risk is not perceptibly different than the person who's at 71. So I still don't sort of fathom how we're not trying to get the risk factor down rather than having a threshold for treatment. And then there was a question about any evidence for PCSK9 therapy as monotherapy in patients not on a statin. I'll just tackle that. There's a great LDL lowering data that's consistent regardless of whether you're on a statin or ezetimibe. That doesn't make a difference. In the trials, the clinical benefit appeared consistent for patients who were on a high-intensity statin, moderate intensity. We had a small number on low or no-intensity statin, but there's no reason to think it'd be any different. Bob, one question was, yesterday some talk about calcium score. What happens if you have a high-risk patient but a CAC score that's 0? Does that give them the warranty for a decade? What's your approach to that?
There are certain individuals that don't have calcification but have higher rates of cardiovascular disease. Those are people with inflammatory conditions such as HIV, where this has been shown. Other populations might include the patients with rheumatoid arthritis. In individuals with familial hypercholesterolemia, they didn't recommend necessarily the CAC score because the lifetime risk is so high. My patient was, afraid of going on cholesterol-lowering therapy, and that's why we obtained this additional test, which gave her the assurance that she needed to get started on treatment, and is now bought into the comprehensive program that was designed for her.
Jamie, for you, what is the evidence that low vitamin D predisposes to statin intolerance?
It's observational at best.
Yeah.
Certainly we check it if someone has a problem. I was just talking to a colleague the other day, and I said it's one of the only reasons I can think about checking it anymore, but I can't show you data that says supplementing actually improves that side effect.
Thank you for listening. Download materials and complete the post-test for instant credit at www.peerview.com/JCD. This activity is supported by educational funding provided by Amgen. This activity has been jointly provided by Medical Learning Institute Incorporated and PVI, Peer View Institute for Medical Education.